This is Selma Schimmel, and you are looking live at the great city of Chicago, which is once again playing host to the American Society of Clinical Oncology, ASCO. This is ASCO's 49th annual meeting, and this year's theme could not be more appropriate: Building Bridges to Conquer Cancer. More than 30,000 of the world's foremost cancer specialists are here, and so is the Group Room, making our 15th appearance at ASCO and one of our very best. Joining me now is Dr. Lidia Schapira, Associate Professor, Department of Medicine, Harvard Medical School, Massachusetts General Hospital. Thank you for joining us today. Welcome to Humid Chicago.
Thank you so much.
Let's talk a little bit about what we may know about various ethnic groups in our country, how they perceive end-of-life issues, what they may or may not understand about palliative care, hospice care, which really are two different things. But what do we know about individual cultures in the cancer dialogue?
We do know that in general some communities are more reluctant to, perhaps because of privacy reasons, perhaps because they feel that they've been discriminated against for so many years, that when we talk about a more gentle way of approaching end-of-life care, they feel they're being excluded from some technological advancements. Whatever the reasons may be, we need to be very gentle. We also need to be very patient, and we need to give really people the information and education they need so that they can make good, measured, informed decision when it really comes to them.
Do you think part of it is also influenced by religion, attitudes of the whole spiritual world related to death?
Very well, maybe. I mean, there may be some things that are passed on in oral cultures and traditions that have to do with, not accepting any limitation on life. That life is not something that we have given, but has been given to us, and perhaps in that spirit that we need to be able to hang on to every last second, millisecond of life, and others who may have an easier time accepting the fact that their illness is sort of in the very last phase, and may have perhaps a more open mind when it comes to discussing death. And one of the ways that we can approach is to discuss a natural death rather than a very instrumented technological death, which occurs more in an intensive care hospital setting. So I think that trying to really understand what it is that people think they need to do, how it is that they feel that they're going to face their death, knowing if somebody believes in an afterlife or not is very important, because perhaps for some people how they die will also affect their perception of what's going to happen to them after their death. For many people it's really a matter of legacy also, of wanting to be remembered in a certain way. And one of the questions that we can sensitively ask when somebody is dying is, how do you wish to be remembered? That often allows us to really, again, have a more meaningful, personalized conversation and help people perhaps accept what at first impression may be very hard for them to accept, which is that no matter what we do, there's very little time remaining.
I know that ASCO would very much like to see the discussion of palliative care, which in this case may not be end-of-life care, integrated into early discussions that a medical oncologist has with his or her patient. And my hope would be if we can begin to have that dialogue and sort of normalize the discussion and make it a part of the natural course. If palliative care for someone may be getting them through, the symptoms-related side effects of treatment, surgical pain, overcoming an acute phase of their cancer. And for some people, it may lead to end-of-life care, and for others, it leads to resuming life. But for everyone, it's about quality of life.
And I think that's a much more organic approach to living with a life-threatening illness and doctoring or looking after patients with life-threatening illness, because we are surrounded by or practice in a context so full of uncertainty. We don't know when treatments are going to work. We often can't tell who's going to have a relapse, who's going to have what we consider a favorable outcome, or who is going to really die of their disease. So I think that the way to start the relationship on the right footing is to start by by building a trusting relationship, and that means that I pay attention to my patient and find out who they are, what means the most to them. I elicit their concerns every time they come in. I respectfully listen. I try to refer. I also tell them that it's important for me to know how they're coping with their illness and how their family is coping with their illness. And so when you start with that kind of a relationship, palliative care becomes part of what you do. You are paying attention to symptoms, and at some point you may introduce the idea that you really need expert help in palliative care. Perhaps this first order of palliative care could be done by most oncologists, but then there may be some more complex needs, usually related to pain management or perhaps refractory symptom management or psychosocial needs that need to be met by people who are trained to do so. So I think that as we think about integrating palliative care, we can think about different tiers of palliative care, some of which can be delivered and perhaps ought to be delivered by all oncology clinicians, but some which really require the specialized attention of people who have dedicated themselves to this art.
Yes.
So it's very nice to start the conversation from the get-go and basically offer a helping hand, offer to listen. Many of the palliative care interventions really have to do with just being open and being able to be flexible and meet the patient where she or he are at, and talk to them in the way that they understand, relieve their symptoms, accept perhaps what trade-offs they're willing to make in terms of living longer or living with a little bit more pain, just in terms of being able to function. Sometimes people make these decisions that in order to continue to function as a driver of a school bus, they're going to take their pain medications only at night so that they can still drive, or whatever it is that is an important, meaningful, personal trade-off in terms of accepting the symptoms or accepting a treatment.
And educational materials that we create really do have to then be developed in ways that are culturally sensitive and respond to
Absolutely.
the different cultures and based on what we already understand, in a way that will resonate, not be threatening, but in a way that will show sensitivity to our understanding of culture.
What we want is for people to talk to us, to tell us what matters to them, to tell us what they're hurting from or about. And the only way we're going to do that is if we have medical cultures that are inviting, that are welcoming, if we pay attention to the fact that somebody else may be experiencing this differently than we would. So what we need to do really is, again, to be open, to develop materials, to develop our clinics, our offices in a way that everybody feels that they're welcome, that they feel that talking about their concerns could be done in a culture of respect, and that if the oncology clinician perhaps is not the best person to meet all their needs, that they will have a low threshold for opening it up and inviting other members of the team with different areas of expertise. It could be pain and symptom management, it could be chaplaincy, it could be social work, to really help the patient and family do the best they can when they've been dealt a bad card.
And I think one of the probably most important things you said is that we need to elicit from patient and family members what are their feelings, measuring how much they know and understand against what their needs are, but most importantly, giving them a voice so we learn what matters to them.
Absolutely right. And one of the themes that's emerging in communication and palliative care is this idea that we need to cultivate prognostic awareness. So we need to help people understand what their prognosis is. But not everybody is ready to do so at the first visit or second visit. Not everybody is even willing to hear. So the challenges for us in terms of communication and, of course, cross-cultural communication are how to respectfully negotiate those barriers with patients, how to help them to be ready to hear what we have to say, and then to deliver our message so that it can be respectful, it can be sensitive, but we really can say what needs to be said and help people prepare perhaps for the final weeks or months of life so they live that time with dignity and as much joy as possible.
Thank you very much, Dr. Lidia Schapira, Associate Professor, Department of Medicine, Harvard Medical School, Massachusetts General Hospital. Thank you for joining us today.
It's my pleasure.